Welcome to the Onvida Health Base Hospital EMS Treatment Guidelines video tutorial series. This is Dr. Franco Castromarin, and you're watching Part 6, Trauma. This video is intended for any EMS provider who's operating within Yuma County with Onvida Health, formerly known as Yuma Regional Medical Center, as your base hospital and administrative medical direction. Please confirm with your chain of command if you are not sure. The primary objective for this Part 6 video is to go over in detail every page of the treatment guidelines in the trauma section. The setup is simple. When I'm comparing a new guideline to an older version from the YRMC protocols on the same or similar topic, the new version will always appear on the right of the screen and the old version will be on the left. They will be labeled in the top left corner of every page, new versus old. Having the old material available for comparison will help you build familiarity and comfort with this new content. Along the way, I'll point out important details on each guideline and share some effective teaching pearls. Remember, you will always have access to this training content, and you can come back to review it at any time at your own pace as often as you'd like. I encourage you to have your mobile device out and use it to follow along as you watch these videos. One of the advantages to this rollout is that we are using the same mobile app vendor called Acid Remap to host our guideline document, so much of the app navigation should be familiar to you already. As you may know from using the Acid Remap mobile app, there's a way to make your own notes. Feel free to use this function frequently as you pick up useful teaching pearls from these training videos. The first page in the trauma section is titled General Trauma Management, and it sets the stage for how we want you to approach all injured patients, including blunt, penetrating, or burn-related. It replaces the old traumatic hypovolemic shock guideline and expands the scope while offering a more comprehensive and practical framework for trauma care. The format here follows a structured head-to-toe approach, but also aligns with the MARCH sequence: massive hemorrhage, airway, respiratory, circulation, and head/hypothermia. That's intentional, and it matches the way I set up the old guideline when I refreshed it back in 2022. The idea is to help you stay focused and methodical, even under pressure, while adapting to the real-time needs of each patient. Let's start with the EMT section. Scene size up and safety come first, as always. In this new version, this step is shown more explicitly. If you need more help, request it early. Then initiate universal care and get to work. From here, proceed with the MARCH method. M is for massive hemorrhage, and this leads the way. We reinforce the need for rapid identification and control of bleeding, and point you directly to the external hemorrhage management page with this hyperlink if you need it. Don't wait to confirm full vitals or start an IV before you stop major bleeding. Hemorrhage control is time control. Airway comes next. If your patient is awake and protecting their own airway, just position them for the best air exchange and apply SMR as indicated. Have a low threshold to apply high-flow oxygen. With major trauma, even if your initial saturations are okay, it is best to aggressively oxygenate before you run into hypoxia problems, if anything, to increase your margin of safety while caring for them. This is especially true with severe head injury. Again, relevant hyperlinks are included. Now, if your patient is heading toward respiratory failure or respiratory arrest, BLS airway techniques come first, as we've mentioned many times before in this training. If you've completed special training requirements, or if you're a paramedic, it is reasonable to insert a supraglottic airway early on, especially when you need to prioritize other life-saving actions. During the respiratory setup, we check the whole torso, front, back, and up in the armpit area for any sign of penetrating trauma or chest wall instability. For open chest wounds, use occlusive dressings. This is also the time where you can stabilize a flail chest as needed. Circulation comes next. First, you should reassess your hemorrhage control efforts that you applied before. Then, if your patient is hypotensive and has an unstable pelvis, apply either a pelvic binder or a sheet. Then you perform a head-to-toe blood sweep for other signs of external bleeding, and also consider the possibility of internal bleeding that's concealed. It's possible for an adult to bleed over a liter of blood into a thigh compartment from a broken femur, even if the skin is intact. So imagine how much blood can hide in the abdomen or in the retroperitoneal space. Speaking of femur fractures, it's during this circulatory step that you should stabilize and splint extremity deformities. Lastly, here's a hyperlink to the blood thinner medication list so you can identify this important risk factor. You'll notice that head and hypothermia are paired here. Both of these are easy to overlook. If there are signs of brain injury, you can refer to the EPIC TBI page. Otherwise, as far as temperature goes, always assume temperature is falling and take active steps to keep your patient warm. Use blankets, turn up the thermostat, and insulate from cold surfaces like the spine board. Never forget that hypothermia is a part of the lethal triad of trauma. The secondary survey gives you the chance to go over everything again and adjust your plan as needed. Reassess everything from head to toe and dig into the history as the situation permits. Now, having said that, this is generally happening once your patient is packaged and on transport. Do not prolong your scene time beyond what is needed to extricate and address immediate life threats. So wrapping up the EMT section, first, this guideline explicitly supports moving patients to the most appropriate facility, not just the closest one. Second, and this is very important, even transient blood pressure drops may signal serious bleeding. Make sure to communicate those concerns to the receiving facility early. Now for paramedics, there's a short but important section for you. Appearing first is one of the life-saving interventions that technically belongs within the March algorithm. We list needle chest decompression with its associated hyperlink. Next, if your adult patient has a systolic blood pressure less than 90, or when you see the heart rate is greater than the systolic pressure, give a 1 liter IV fluid bolus. You can repeat this as needed. So now let's take a minute to focus on the new change. We are adding a drug called TXA, which is tranexamic acid. This drug is a procoagulant, and there's accumulating evidence that can reduce the need for surgery and transfusion and improve survival for patients with hemorrhagic shock. For patients within 3 hours of injury who either have confirmed shock or are at risk of developing hemorrhagic shock, you give 1 gram of TXA for adults. It's important that only patients who are within 3 hours of injury get this drug, since the benefit seems to go away after 3 hours, but the risk of clotting complications increases after 3 hours. In fact, the earlier you give this drug, the better the effect. So I'm looking at our rural agencies in particular here. This is very important for your patients with hemorrhagic shock. Now there's a pediatric box, as you can see. It's all the same idea. If you see that the child is tachycardic with signs of poor perfusion, you're going to give a fluid bolus at a size and weight appropriate quantity. Repeat as needed. For the pediatric TXA, the dose is 15 milligrams per kilogram with a maximum of 1 gram to match the adults. Finally, we wrap up this guideline with a reminder to remember pain control for these patients. So that's the updated general trauma management guideline. You'll see that while the format is new, the core principles are familiar. Stop the bleeding, protect the airway, support circulation, keep the patient warm, and move with purpose. This page ties together a lot of fundamental trauma concepts that previously were scattered across different guidelines. It's designed to help you stay organized, reduce guesswork, and ensure that nothing gets missed. These next 2 pages are the national guidelines for field triage of injured patients and ramp triage. These pages are exact copies of the ones that currently appear in the YRMC document, and they contain no new information. Next is the termination of resuscitation guideline for trauma patients. Again, everything here is the same as the current guideline, but under the paramedic section, the age cutoff for contacting online medical direction has come down to under 15. Before, this was under 18, so please keep that in mind. Beyond that, other than flipping the order of penetrating versus blunt trauma here in this section, everything else is unchanged. Next up, we have burns. Hopefully you're starting to notice that the current YRMC guidelines for trauma are mostly the same as what is found in this Onvida document. This is because both documents came from the same source material. This page is no different, even though the layout seems completely different. Yes, the new material is formatted to fit the new layout of BLS and ALS split, and it sticks to a bulleted list style, but I'll show you that the medical care is the same. As always, we have our inclusion and exclusion criteria shown here up top. Next, we add these standard steps such as verifying scene safety, starting universal care, and checking for cardiac arrest. From there, we have our airway steps, and these are carried over unchanged from the old guideline. Next is this stop the burn information, also carried over unchanged. We round out the EMT section with a total body surface area calculation, determining electrical source if it's an electrical burn, and we add some hyperlinks for cyanide and carbon monoxide poison management. Now these are new, were not included in the old version. Under the paramedic section, we carry over the exact same fluid treatment and monitoring steps as before, and then we finish up with pain management. So taken as a whole, aside from this page layout difference, all of the core information is the same. Next up is this burn triage flowchart. This is an added resource for you to know which type of burn injuries might end up needing care at an actual burn center, which, as you know, in Arizona is the Arizona Burn Center at Valleywise in Phoenix. This is here simply to help you in conversation with Onvida Health main campus online medical direction when determining the best destination for transport. Depending on the circumstance, this information could help you decide to activate air medical transport early from the scene versus going ground to Onvida first for stabilization prior to transfer to Phoenix. Alternatively, it can help assure you that stable patients with burns that don't fit these criteria can in fact be transported to one of our local facilities in the Yuma region. The next page is the burn estimation charts page. Again, good news. This is totally unchanged from prior, no new information here. Next is the external hemorrhage management page. Again, more good news here. Aside from the layout change to remain consistent with our enhanced new format, all of the information here, including the stepwise approach to bleeding control, is unchanged. Next up is extremity trauma, and this page is new. It adds information focused on managing amputations, entrapped or crushed limbs, as well as fractures or deformities. The EMT section covers appropriate steps to evaluate the injury, looking at details such as extremity function, neurostatus, as well as limb perfusion. Next, it covers splinting, elevation, and using ice packs to limit swelling. At the bottom here, we cover proper packaging and transport of an amputated part. Now notice here the caution not to place the part directly onto ice. We round it out with a pain management step. Under the paramedic section, we include information relating to crush injury. If you've been in the field long enough, you've probably encountered a patient who may be pinned under heavy machinery, maybe trapped inside of a vehicle or stuck beneath a collapsed structure. These happen to be some of the most complex and physiologically dangerous patients we manage in the pre-hospital setting. In the world of medicine, we call this a halo event. High acuity, low occurrence, much like a cricothyroidotomy. What makes crush injury so challenging isn't just the visible trauma, it's the metabolic time bomb ticking beneath the surface. When muscle is compressed for an extended period, it starts to break down and it releases massive amounts of potassium, acids, and other cellular components. The real danger often begins at the moment of extrication, when that toxic load is suddenly released into the patient's systemic circulation. That's when things can spiral into life-threatening hyperkalemia as well as cardiac arrest, and this happens very quickly. This new section helps you to stay one step ahead of that cascade, so let's walk through it. First, you'll want to start continuous cardiac monitoring to identify early signs of hyperkalemia. You're going to look for tall, peaked T waves that look like they can swallow up the entire QRS complex. Or, as the potassium climbs higher, the QRS complexes themselves will become more and more wide. We've included the link to the ECG changes in hyperkalemia appendix right here in the guideline for quick reference. While you are working on applying the monitor, start administering high-flow oxygen to the patient. Then comes a key preemptive step. If possible, initiate IV or IO fluid boluses of 10 to 15 milliliters per kilogram before you free the trapped extremity. The goal here is dilution, buffering the effects of what's coming once circulation's been restored. For patients with a significant crush injury or prolonged entrapment, you're now directed to consider sodium bicarb. The dose is 1 milliequivalent per kilogram with a max of 50 milliequivalents administered over 5 minutes. This is meant to help correct acidosis and blunt the poisonous effects of potassium shifts during reperfusion. In this final section of the page, we include the other medications you have available other than sodium bicarbonate to treat hyperkalemia. As always, we split the dosing by age group. In order of preference, first you're going to administer either calcium gluconate or calcium chloride. You don't need both, just pick one. These drugs are immediately cardioprotective and help stabilize the cardiac membrane. There's a safety reminder here to ensure that your IV or IO is patent before administering calcium chloride. This drug is a vesicant and can damage veins and soft tissues if it extravasates. Next up, you need to add albuterol, 5 milligrams nebulized. This might feel like a departure from the usual trauma medications, but as it happens, albuterol drives potassium back into the cells, making it a valuable adjunct in treating hyperkalemia. It acts pretty quickly. In fact, if you watch the cardiac monitor, you can actually see the waveform improve during the SVN administration right before your eyes. So that wraps up the new extremity trauma crush injury guideline. This is an important update because it gives you clear anticipatory framework for one of the more dangerous trauma patterns you're going to face. What to do before and during extrication can mean the difference between getting a stable patient to the hospital or having your patient deteriorate suddenly into cardiac arrest. Next up is thoracic injury management. This guideline essentially replaces the needle thoracostomy procedures page from the old version. Starting up top here, this inclusion criteria information is copied almost word for word from this indications section on the old version. Note the caution statement reminding you that tracheal deviation, distended neck veins, and cyanosis are late and unreliable findings when a patient has tension pneumothorax. From there, we pick up with our standard BLS-ALS split. BLS care involves sealing open chest wounds, stabilizing flail segments, administering high-flow oxygen, patient packaging, as well as transport. The paramedic section is devoted to the needle decompression procedure itself. We list the steps of the procedure here, as well as the breakdown of landmarks, and the same medical illustration gets used here. This gray box includes the needle size selection by age group. Otherwise, the language itself is pretty much the same, so there's nothing new to learn or memorize. Next up is epic traumatic brain injury. As you might recall, EPIC TBI is an evidence-based patient care bundle that came out of research conducted at the University of Arizona many years ago. This care bundle follows a very specific process, and that process is not changing with these new guidelines. So as with many of the other guidelines in this trauma video, there isn't anything new to learn or memorize. The content is the same, it's just the layout that's been updated and enhanced. So please note that we combine both the adult and pediatric care on the same page. As you can see, we break down the bundle into an airway, breathing, circulation, and disability framework. Most everything is captured up in the EMT section. The paramedic section really only contains added management steps for airway management and circulatory support in accordance with an ALS scope of practice. For airway, we emphasize the importance of early aggressive oxygen administration to prevent any single hypoxia episode. At minimum, even with a patient who is breathing spontaneously with an intact airway, we recommend early high-flow oxygen. Note this caution statement to aggressively prevent any desaturation below 90%. If you find yourself needing to ventilate the patient, note this hard stop icon reminding you never to hyper or overventilate. In this section, we list the ventilation rates by age group. On to circulation, we direct you to continuously monitor vital sign trends and warn you that even a patient with a blood pressure that is barely approaching anything resembling hypotension needs corrective action before they deteriorate to true hypotension. In such a scenario, the paramedic can find the fluid bolus information they need down here. Under disability, we focus on checking and managing glucose, bleeding, and spine injury precautions. We finish off the paramedic section with some general commentary and precaution elements that pertain to advanced airway management. Next up is spinal motion restriction. Again, the content is the same, only the layout changes. Taking a look at the old version, let's look at how I group the information. This top box is all the elements that would automatically trigger mandatory packaging of the patient. That same information is now listed here. These elements apply to all ages, and you'll notice that they are all some type of exam finding. Next, in this section, we include not exam findings, but rather high-risk injury mechanisms that inform when you probably should package a patient. As far as mechanism is concerned, there are differences based on age group. In adults, a high-risk mechanism means that you should strongly consider packaging. For example, you see this caution mark flagging anyone over age 65. For a patient of this age group, I would certainly at least apply a collar unless there is specific contraindication present. The idea is that for these patients, the default setting should be to package them, but there is room for not packaging them if there is some sort of other safety concern or some conflicting priority. On the other hand, for children, as is emphasized with this bold comment, high-risk mechanisms are actually automatic mandatory signals to package children, just like exam findings were up in this area. Now, this third bucket is characteristics that are actually low risk. Any of these suggest that it is probably safe and reasonable not to package the patient. What's important to remember here is that low-risk characteristics have never been studied in children. So just like on the old version, I have a hard stop reminding you of this. Don't apply these elements to your decision-making when taking care of pediatric patients. This information here is additional commentary on what constitutes proper patient packaging, including this hard stop to remind you that the trauma surgeons do not approve of us just slapping on a collar and then transporting patients in a seated position. If the collar goes on, the patient should at least be lying down as close to flat as possible. But hopefully everybody realizes by now that it is not mandatory to put every SMR patient onto a backboard. The ambulance gurney is adequate. Now, before we take a look at the final page in this section, I do want to share one huge pet peeve of mine as it relates to spinal motion restriction. It seems that people like to use the phrase SMR was positive or SMR was negative, either during a courtesy notification, a handoff in the trauma bay, or on their PCR documentation. The thing is, SMR is not a test result like a pregnancy test. It isn't something that is either positive or negative. Spinal motion restriction is an assessment and decision-making tool, as well as a menu of different patient packaging techniques that we apply to an injured patient when either extricating them or transporting them to the hospital. The proper way of communicating that is something along the lines of, my SMR assessment was normal and no specific packaging was indicated or applied. Or you might say, patient had severe cervical spine tenderness and could not rotate their head during the SMR assessment, therefore collar was applied and the patient was positioned supine on the gurney for transport. So don't think of SMR like a pregnancy test. It isn't positive or negative. Don't communicate in those terms, and please stop teaching newer medics to communicate like that. Let's stop trying to propagate this clumsy terminology. Okay, with that out of the way, let's look at our final guideline in this trauma section. It's called fall injury, minor injury, and lift assist. This is new content for you. So you all know this type of call. Usually it's an elderly person who falls from a standing position. You assess them, they seem totally fine. Oftentimes the patient doesn't even want a detailed exam or have a prolonged conversation about it, and they just want to be put back in bed and get you out of their house. How frustrating does it get when the patient actually has dementia and you're trying to understand if they're at their baseline in terms of confusion or disorientation? Is it their baseline or do they have a head bleed? Who knows? With that in mind, here's some fun facts about lift assist calls. Lift assists are a growing portion of EMS call workload as our population gets older. Up to 50% of these patients require repeat EMS visits within a month, and 1 out of every 8 end up in the emergency department after the first call. These patients have a higher mortality at 14 days following the lift assist call. And up to 4% of these patients will have a repeat EMS call within 24 hours. The bottom line here is that these calls are increasing in frequency, they carry a measurable clinical risk, they consume limited EMS resources, and they offer a really important opportunity for future injury prevention and early intervention. It's important that you treat these calls as sentinel events, and this is why we developed a standardized guideline that incorporates some screening, some better documentation, and some consistency in practice. So have a look at these statistics from the state of Arizona. As you can see, falling is the number one mechanism of injury among all EMS patients, and it's actually the top cause of death from trauma in absolute numbers. Did you know that 9% of patients over 65 will have a significant injury such as a subdural, subarachnoid, or epidural hematoma on head CT after a fall from standing position? This doesn't even consider the use of anticoagulation medication, which obviously increases that likelihood. Even more concerning is that of those patients who had abnormal head CTs, 15% of them had normal exams and no other high-risk criteria other than their age. The most common finding on the exam was abnormal mental status, but how do you square that if the patient has dementia at baseline? Yeah, there's lots to unpack here, so let's dive into the guideline. Here at the very top, under the inclusion criteria, we have our first caution mark directing you to treat these interactions as a full medical or trauma encounter. This obviously means that you're going to need to complete a patient care report. In the EMT section, we begin with standard care as well as an SMR assessment, followed by key medical and trauma evaluation elements such as checking for altered mental status, screening for stroke, getting a full set of vital signs, looking for orthopedic injuries, and checking the glucose. Next, we take some time to screen for other contributing factors. In other words, it's time to do some detective work and try to better understand the circumstances that led to that fall. This is where you might pick up some clues that this fall was in fact a sentinel event and needs to be evaluated in the emergency department now, instead of the following day or the following Monday or whatever. Think syncope. Look for dizziness that indicates a possible stroke, ask about chest pain, weakness, etc. This list includes elements that require online medical direction if it's ultimately decided that the patient is not going to be transported to the emergency department. And this section has some final screening and safety checks along with the recommendations to contact the healthcare power of attorney if that applies. Finally, this paramedic section finishes off with cardiac monitoring and ECG recommendations as part of a routine ALS assessment. This concludes part 6 of the Onvida Health EMS Guidelines video tutorial series. Thank you so much for watching.